There are so many things that are really important right now. So ramping and overcrowding in hospitals, huge issue. Access to general practice, massive issue. There's all of these things in health that are competing priorities. One of the things, and again, I think coming back to seeing what we need to do as a solution, is that climate solutions are also health system solutions.
I'm Dr. Louise Messara, and this is the Future Health Podcast. As our planet faces unprecedented environmental challenges, the impact of those changes on human health is becoming increasingly evident. Today, we're going to delve into the complex relationship between climate change and healthcare, shedding light on the profound implications for healthcare professionals and patients alike. And we'll explore how we can adapt and innovate in response to these challenges. Today, we're lucky to be joined by a true changemaker, Dr. Kimberly Humphreys. Kimberly is an emergency medicine physician and public health practitioner with a profound dedication to addressing the intricate relationship between climate change and public health, holding advanced qualifications, including as the Harvard Climate Change and Human Health Fellow in 2022-23. She is currently the Climate Change Lead at South Australia Health. Welcome, Kimberly. I wanted to start by asking if you could pinpoint for us the moment that you really thought, okay, I'm going to reframe my thinking as a clinician in relation to climate change. Was it something you read, something you saw, someone you met? What was that moment for you?
I think it was more a growing realisation. So there was never a kind of thunderbolt moment where I went, oh my goodness, this is a problem. I'd finished my emergency medicine training and begun during that time to be more interested in public health. So gone on to do a Masters of Public Health and then had finished my exams in emergency, working clinically, and really started to see the impacts of climate change on my patients. So working in the Northern Territory and also regional Queensland and South Australia. And it started to really wake me up that this is not an abstract problem in the future. This is a real thing now that is relevant to my practice and all of the patients I'm seeing.
So when you're talking to your friendly clinician, what's your sort of elevator pitch when they're struggling to make that connection between climate change and clinical practice?
I still get that question
I'm
all
sure
the
you
time.
do. Yeah.
What has climate change got to do with anything we do? Really, fundamentally, it is the biggest threat to the health of our patients. And I think anyone who works in health got there from a position of caring about people and wanting to see the best outcomes for patients. So that's really where I come from, is to say this is the greatest health threat. Out of all of the things that we face, this is number one going to make the biggest impact. And for that reason, we need to understand what it's going to do to our patients, but we also need to understand what we need to do as clinicians to kind of reduce that impact on our patients and communities as well. And it's completely relevant to the practice of everyone in health.
It's hard when you're already a busy clinician, potentially with a full load. You start developing this sort of burning passion to really think about this new space and integrate that space into what you're doing every day. How do you maintain a personal drive to try to manage both of those lanes? Or do you think that they've converged now and they're just one?
Right. So I think for me, they've converged. But it's a tricky question. So I started off being a full-time emergency specialist, and I have now gone almost to being full-time in public health working on climate change. And the reason for that for me is just the magnitude of the problem that we need to confront, and seeing what it's going to do to our patients has really provided that drive for me to say, yes, still care deeply about emergency medicine and the practice of emergency medicine. But more than that, this is relevant to not only emergency medicine, but medicine and health in general. And I just feel this incredible drive that I need to be a part of that change.
Do you think that's you? I mean, do you think you had this incredible drive which was dedicated into a part A of your life, part B, part C? Or do you think really this is sort of a new vigour that you're bringing to this part of your career?
I think it's a new vigour. I think that because I still practice as an emergency physician, and now I just kind of bring a different perspective to that. And I think there is a growing community of people who are working in medicine and health who still are passionate about whatever it is they trained in or wherever they work, but going, actually, if I don't pay attention to this and don't bring it into my practice, then I can't just turn a blind eye.
So, I mean, I think every generation has its burning platform, its crisis, its problem. And I wonder if you're finding, as you're talking to people of different ages and stages, what other problems are you competing with in people's minds? As, you've said it's the critical issue. It's a critical issue for all of our patients. What are some of the other people's critical issues that you maybe bang up against when you're sort of having that conversation?
Right, because it's not the only thing. And I think we see that when we look at what matters to people. So what matters to the average person on the street? Cost of living is incredibly high. If you can't put food on the table, then are you really going to be thinking about what a heat wave in 3 or 4 years might do to you? There's so many things that are competing in this space. I think poverty is such a significant issue, and there's a lot of conflict in the world, and there's all these big things. I think one of the things about climate change and the changes we can make is that can hold a mirror up to all of these things. And we can use climate change and our position in health within that to really create change and address these underlying inequities. So I don't see it in conflict. I see it as a mechanism to produce these societal changes that we need to produce, that we need to really attack to get better equity in our communities. It's part of the solution, I think.
I don't have any doubt that you're a compelling advocate in the space. I wonder in health, when we're challenged with ramping ambulances, workforce shortages and challenges, all of these sort of day-to-day, because as you say, we're not necessarily preparing for climate change. It's here now, but sometimes some of the storytelling is around what is coming. And I think it's very challenging for people sometimes who feel like they're in a disaster zone to make that space for the urgent. Do you feel like hospital staff, hospital administration are making the space that they need to now? Because a lot of the redesign and the changes we need to make, even if we are thinking about 5 and 10 years as critical moments, the changes have to be made now. How do we find space in amongst all the urgent?
It's such a good question because, as you said, there are so many things that are really important right now. So ramping and overcrowding in hospitals, huge issue. Access to general practice, massive issue. There's all of these things in health that are competing priorities. One of the things, and again, I think coming back to seeing what we need to do as a solution, is that climate solutions are also health system solutions. So it's not about saying, okay, we're not going to worry about ramping because we need to really think about climate change. It's thinking about what do we need to do from a climate perspective, reducing our emissions, adapting our communities to build better resilience, that are also health system solutions, because essentially most of them are the same things.
100%. So I want to take a step back for a second. You've just had a really fascinating 12 months spent in the States. You're a Harvard Fellow for climate change. I mean, what amazing exposure and experience that must have been. I wonder, did you come away from that with a sense of what your personal work is going to be? Are you going to be educating? Are you going to be an advocate? Are you going to be in research? How does it shape your thinking about where you can be most impactful in the system?
I think for me, the biggest places where I think that personally I want to be involved and make an impact, first of all, is the role of health professionals in reducing global carbon emissions. So we have such a powerful voice as health professionals, and we know that health is a very compelling argument to the general public and to those around us for reducing carbon emissions and decreasing fossil fuels. That is the biggest thing we need to do. Every fraction of a degree that we can mitigate has magnitudes of impact in terms of reducing morbidity and mortality and deaths in our population. So that is huge. That's what we need to do, is move that needle more than anything else. Secondary to that, a real passion of mine is adaptation and what we need to do to build community resilience, because we know the impacts of climate change are already here. Building sustainability, high quality, low value care in our health systems is also really important. So a lot of work to do, a lot of things I'm passionate about.
So the vision's clear. How do we operationalise that as a clinical workforce? What do you want us to do under your leadership? What can we do?
Right. And that's hard again, right? Because everybody is dealing with all of these pressures. Many people feel burnt out because of the issues we mentioned before, overcrowding, all of these things. And how do we say, this is another thing you have to do? I think part of it is building it into the work that people are already doing, and really the messaging that in many ways it can make things easier. If we redesign our processes to have these good outcomes for our health sector, it's actually going to make your job easier. You're part of the solution. That's advocating on climate change, but it's not saying this is another extra job that you need to do.
Yeah, I mean, that's interesting, because I was going to ask a little bit about whether you're still having to do any convincing about climate change as an issue in and of itself, or whether you sort of avoid that by just going straight to these are the opportunities for our patients, these are the opportunities for our system, and you almost don't even, we can skip part one of the debate, maybe. I don't know. How do you feel about that?
Yes, and I think there's still, amongst the clinical workforce, there's still a little bit of, the greenies in the corner type mentality with some people. And I think there's two parts to that. One is not everybody understands the intersection between climate change and health. So there's a bit of an education piece there. But secondly, yes, it's really reframing it as these are solutions. It's better quality care. It's costs less. It's decreasing carbon emissions. It's just whatever angle you want to come at, whether it's safe, high quality care, whether it's cost, whether it is understanding carbon emission reduction is important, it's better outcomes for our patients. So it's meeting people where they're at.
What are the sort of day-to-day elements if we take it from system down to the individual person working at the coalface? What are the changes that they need to be alert to, both in, I suppose, their clinical world and even maybe in terms of what we're being taught, trained and educated about? How do we bring the idea of the impacts of climate change into our syllabus and curriculum?
Talking about the clinicians first of all. So I think there's a lot of work that we need to do to ensure that our clinicians understand how to manage people who are affected by climate change, because we do see it. We see people who are affected by heat. So in emergency, we've always seen that, but now we see more of it because we see more intense, more prolonged heat waves. We see that intersecting with social determinants of health. So people who are sleeping rough, who don't have access to air conditioning. We haven't done a great job of ensuring that our clinical workforce understands what they need to do and their role in the advocacy of that. So if you have a person who comes into emergency, for example, it's having that conversation. Maybe they're not in a critical place. Maybe they've just come in for something else, but you know that there's a hot summer ahead. It's having that conversation with them about their medication, how that might interact. Do they have a heat action plan? Do they have air conditioning at home? And addressing those things before it becomes a crisis. So there's a real job for us to do to make sure that our clinicians understand that. And then we have the role of emerging infectious diseases.
Yeah.
You know, we saw Japanese encephalitis we'd never seen in the southern part of Australia. And a lot of our clinicians wouldn't think to look for these things because we've never been trained that they're an issue in our patients where we live as well. So there's a lot of education of postgraduate professionals that I think we need to do still.
And what about undergraduate education? People are being trained in different ways. I was the old 6-year course. You sat in a room for 4 years and then you finally got to see and touch a patient right at the end. But, you know, a lot of the education is so much more integrated now in terms of even systems. And I'm thinking, you know, if we're learning about the cardiovascular system, do we learn about it also in terms of, well, what is the impact on someone who has cardiac issues, cardiac medications in relation to heat and climate change? Like, should it be part of the conversation at that level? And do you know if it is?
Yes, so it needs to be woven in exactly like that. So the same situation for me, came through that 6-year course, I think probably mentioned climate change once. Over the last few years, it's been maybe a lecture or two for a lot of medical schools, but it hasn't been woven into the curriculum, which is exactly where we need to go with it. Much like we teach cigarette smoking and the impact on the lungs and the heart, we can't have climate change as a special topic. It needs to be integrated through public health syllabus. It needs to be integrated across all of the organ systems right throughout the curriculum, just as this is an impact that will affect all of our learning in medicine. And I think there are definitely places where this is happening now. So Harvard Medical School year before last introduced that model, and literature that came out last week suggests it's going really well. And I know a number of medical schools in Australia are doing similar things or really integrating it across, so horizontally and vertically through the curriculum, not as a kind of special theme at one point.
So interesting. Okay. You can't see a website or read a paper without thinking about the mental health situation for young people and all people in Australia today. The numbers just seem to be spiralling, and I wonder how much of that is related to sort of eco-anxiety, eco-depression, and how prepared we are as a health system, especially at the front door, for dealing with that sort of tsunami as well. Are you seeing, even maybe amongst the workforce, are you seeing an increase in people's preoccupation around their sort of anxiety related to climate change?
Definitely. And I think for health practitioners, we're all potentially patients and practitioners in this space, right? So eco-anxiety, eco-grief, and also many of us will work and live through these extreme weather related events. You know, we will work during bushfire, we'll work during a flood, and then we're dealing with all of those feelings and providing care. So certainly I think we see that within our health workforce as well as within our patients. Then the question is, what do we need to do about that and how do we tackle this huge problem?
We talked a little bit before about the idea of the sort of the brief interventions. It's like, how many people can we badge who are able to give these brief interventions? Because if we try to limit it to ED doctors, that seems like a crazy idea. We obviously have the primary care practitioners, but we have so many people in the health workforce that have interactions with the community and our patients. And it's an interesting question, who we can share this role with. As you say, sort of doctors have always had a little bit of a position in society where, we say something and people might take it quite seriously. But, I think some of the most trusted professions listed year after year, paramedics, nurses, there's a lot of different health workers that are trusted voices in our community. I just wonder about how we might corral the broader workforce to be having those brief interventions, when they're doing allied health assistant work, for example. How far are we from being able to harness the power of our health system to be really preparing?
Exactly, hitting the nail on the head with power of the health system, because there's a lot of us and there's so much we can do, and pharmacists as well.
Yeah.
So many people in communities have contact with their pharmacists and see them as a trusted person as well. I think one of the key things is changing from this mindset of, it's sitting down having a lecture with a patient being like, you need to understand climate change is real and it has an impact, to having the kind of conversations that a pharmacist or a GP or a nurse might have with a patient about their blood pressure, and really looking at how we need to provide the resources and the training to just be able to just integrate this into the kind of conversations we have and build that momentum. So I think part of it is changing how we think. Part of it is not just thinking in that it's the doctors who are going to solve the problem model, and really being multidisciplinary about this, and then looking at how we resource that too, because everybody is time poor. No one has time to do the jobs they're already doing. How can we make this work in a way that is actually workable?
When we think about the social determinants of health, and it just seems to sort of be this interplay, are we best to just think of climate change as a social determinant of health? Is that the way we should be framing it and thinking about it? And if that's the case, is there a job for a sort of reprioritizing in health, how we really look at the parts of the human, the whole person, that we could assist to really maybe change the funnel of action towards the pointy end of our health system? I suppose I'm getting to prevention and public health and population health, but it feels like it's a reorientation of the whole system that we may need to be considering.
So I think that's my utopia, is just completely changing how we think about things and what we need to do, not only for climate change, but to address all of these other things. So how do we see people as a whole as part of their environment, not just this is the problem you've come in with? And I think part of that is many of us have been brought through this medical system that's so pathology focused, that so it's a heart attack, it's not what about this person and all the points that led them to there. We know that primary care and public health is the most cost-effective way to build health and resilience in a population. One of the issues with investing funding in that, of course, is it takes a long time to see the results. So it's very difficult to say, when we see all this overcrowding and all the issues we have, the solution to that is better public health, investing in our GPs. But how do we shift that, and how do we mobilise finances to make that happen when we won't see the results for quite a few years? It's a really tricky thing.
It is a tricky thing. Population health, and then we have subspecialised medicine. It's quite an interesting dichotomy. But do you ever see a time when maybe climate change medicine is going to be its own subspecialty? Or are we losing the point, and does it really just have to sort of sit within all of us?
I think it needs to sit within all of us. And look, that may happen. We've seen just next level subspecialisation of many things, I think, within medicine, particularly overseas. I wouldn't like to see that happening. I'm grateful that there is now extra programs and extra training that are available to health professionals so that we can understand and work better in this area. But it needs to be part of the job for all of us, so that everybody in their particular area can be part of the solution. So we're not siloed, so it's not the climate doctors over there whose job it is to solve this problem.
So if we think a little bit now at a system level, and we just talked a little bit about how do we wrench money from the system and put it over here when the incremental improvements are going to take a long time. I'm conscious that in America, there are now sustainability officers. There's a workforce around the economic benefits of sustainability. And I just wonder, are there genuine savings to be made that maybe we could make an argument that, it's a circle and we'll take those resources rather than starting with a diversion of acute resources. Tell us a little bit about what you saw in America and sort of the commercial aspects of this from a health system perspective.
So I think there's such a strong financial argument we can make. We know that climate change estimates are it's going to cost something like $1.1 trillion to the health system in terms of impacts on health. That's a lot of money. And if we can move the needle a bit on that, that's huge. Yeah. In the US, I think one of the things, because the healthcare system is so highly privatised, it is seen a lot more from the business risk model. And I think because of that, there's been an appreciation of the fact that this does save money. So sustainability officers are shown to save money. The work they do creates that circle. You've got cost savings that are then reinvested. Most organisations that I talk to in the US, most of the hospital systems have a chief sustainability officer. And that is primarily based in the risk that they can see to health in the health system, but also the fact that they know, and there's a lot of evidence on this now, that doing these sustainability improvements will generate income for them and reduce costs.
So there's a genuine return on investment.
It's a genuine business case that can be made that's got nothing to do with the health of people, although that's obviously really important.
I mean, it's great when you can make both arguments.
Exactly, yes.
Where are we at in Australia in terms of that sort of way of thinking?
I think we've still got a little way to go. And part of that is we generally have a public health system. So there's not that same kind of business mindset to the same degree, I think. There are many cases, there's been quite a few hospital systems now that have sustainability officers that have been shown to save costs and reinvest that in the system as well. So there's certainly the literature out there and a really good case that's to be made. And I think as part of that as well, we need to think about all of the acute issues and how much that costs. So how much a person attending a hospital costs the system, not in terms of carbon emissions or the quality of their care, etc., but what is the cost? And anything that we can do at the front end of the system, now I'm not just talking about public or primary care down the track investment, but I loathe the term hospital avoidance, but any of the different strategies that we can think about how we might redesign our health system will save money as well, and will address many of the acute problems that we have that are costing money and really providing that significant burden to our community, like ramping and overcrowding.
How does virtual care fit into that? Is that just in the sustainability model? Is it a plus, a minus? Is it neutral?
So I think we need to be careful with virtual care. I think it's not the panacea for everything. And then we also have to consider the fact that cloud-based systems, that generates carbon emissions as well. So it's not a zero neutral sum game in that respect. There is a great place for virtual care, I think, in terms of ED avoidance. So we're looking at residents of residential aged care facilities. If we have a good virtual care model, perhaps they can get their care and their review and they don't need to go to ED. That's great for them as patients as well as saving costs to the system. Yeah. People in remote communities who can get a good quality consult now don't need to travel to the city. There's many, many ways that virtual care can really relieve that burden of the hospital system. We just need to be careful about not replacing those instances where we really do need face-to-face care. I don't think that will ever go away.
Sure.
So it's just really being cognizant of what are we using it for, where does it add value, and deploying it in that way.
I mean, you're in a unique position having just looked at two very different, working in the Australian health system and just spent 12 months looking at the American health system. And yes, fundamentally there are significant differences. But before we started recording, you mentioned that your experience with the Australian system on return, you'd seen some significant change. Tell us a bit about that.
So it's very interesting. I've been involved in climate change and health probably 5 or 6 years now, even before I went to the US. So I moved over there in July 2022 and I felt still very significantly like we were pushing against a brick wall, and it was so hard to get anything done, especially within health systems. It was still very much, that's a nice little niche project you've got there, difficult to get an authorising environment, difficult to get legitimacy behind it. When I came back in July 23, it felt like there'd been a significant shift. Now, difficult to say why exactly that is, but the environment seemed a lot more, it's time to kind of get this done. It seemed within more serious areas, I think, of the health system, there was that acceptance that actually this might be a problem for risk, for infrastructure, for long-term sustainability and health of our communities. It's actually a problem that we're now appreciating.
Okay, that's good to hear. When we think then about at a hospital level, redesigning the entire health system, that's a big challenge. Let's do it. But big challenge. If we go to a hospital level and think about the programs that an individual hospital could look at to start implementing meaningful programs of change, I think New South Wales, we're really trying very hard around the reduction of waste, reduction of duplication of investigations and things like that. Are there other initiatives and innovations that you're across now that we should really be thinking about when our chief executives and general managers are thinking at a hospital level?
Absolutely. And I think you've touched on some really, really important ones there as well. High quality, low carbon care. And part of that is reducing the tests that we order, trying to get away from this just in case medicine. Looking at all of the reasons that is. So a lot of the pathology that we do, a lot of the radiology that we do, we don't need to be doing it. There's an estimate that 40% of the clinical care that we provide is either harmful or low value care.
Wow, yeah.
So that's a pretty big chunk that we can do something about. And I think part of the solution, and even on a hospital level, we really have this very binary mentality of either you see your GP or you go to ED if you're sick. But what about the in-between? So if you're looking at an individual hospital, what can we do to kind of intervene on those patients that maybe actually don't need a physical emergency department? Do we look at more kind of, not necessarily urgent care, but heart failure clinics, or more subspecialty you can pick up a phone and actually maybe there is more of a 24-hour clinic we can get you into before you're that sick that you need ED. Moving our workforce out of hospitals, more into the community, and just reframing how we think about healthcare. Individual hospitals can do that too. So I think fundamentally it's a big challenge, and it's shifting the culture of our health system. But there's a lot we can do, which is quite exciting.
And it's not just for clinicians. We can talk to the business managers around procurement decisions. We can talk to kitchen staff about plant-based diet. I mean, there's almost something for everyone.
There is, absolutely.
Digging into here.
Whatever area you're working in within health, there's something you can do, right? So whether you're in an operating theatre and you're thinking about anaesthetic gases, or you're thinking about the single-use items we have, or the water tap that keeps running, whether you are working in allied health and that makes you think about what we can do for our patients. There's just so much that all of us can do, and it doesn't need to be in a big way. It doesn't need to be completely changing our system. Maybe it's just something you incorporate into your practice, but there's many opportunities there.
In health, we often like evidence. I was just thinking about you talking about America and the private system, and I was thinking about, as a public health system here, the sort of data that we have available to us, which as data sets is probably quite unique. Are there interesting research projects that are underway that you can tell us about? I'm just keen to see where the sort of the academic thinking is heading.
It's so interesting because I never really appreciated how good our data was until I went to the US, and I would just kind of chat about, what we have access to. And this is in Boston, this is at Harvard, where you would think that would be kind of the epicenter, and they're like, cannot believe you have access to this great lake of data because of our public health system, because of how our public hospital system is set up. So there's a lot we can do drawing from our different data sources. We have all of this census data. We have great kind of population health data about vulnerabilities, our socioeconomic indices, and all of the data we have about why people present to hospitals, how many people present, all of that. So bringing these data pieces together, we can get really nice pictures of the particular vulnerability of our populations, and then look at how modelling of climate change impacts will intersect with the most vulnerable populations, and then look at what we might do to be able to mitigate some of those impacts on those populations as well. So there's quite a bit of work going on in that area, which is exciting.
When you think about a resilient health system, what does that mean to you?
So one of the issues I think when we talk about resiliency is it means different things to different people, right? And often if I say something is resilient, then a lot of people kind of go to the wellbeing side. Because that's what we've used resiliency before. To me, a resilient health system, it's both one in which the people within it are able to survive and thrive, that our health system can withstand the impacts of climate change, but also that we can come out of it with really high quality care as well. So it doesn't need to be kind of patching up the dam that's about to break. It's really thinking about what can we do now that actually is going to make things better for our community, better for our workforce, better for everybody who works in healthcare and all the communities that we serve. So we need to see climate change as an opportunity to address all of these problems we have, and an opportunity to really build this much better system for everybody.
Is there a piece of work to be done on the MBS schedule? Like, when we talk about reforming health, it's hard to go very far before we have to think a little bit about who should be doing what, why should they be doing it, and how should we pay them to do it. And when I hear you talking about resilient systems, but also, low value, high value care, it feels like we're potentially missing an important piece of the conversation, which is going to be important for us to make any of these other changes. How can clinicians really be leaders in this space and be open enough to these conversations, which sort of butt up against scope and professional identity and all of these other elements?
And it's such a thorny question. That's a really challenging thing. And I think in health, we're becoming quite good at standing up and saying, fossil fuels are a health hazard, climate change has big impacts on health. But we're not as much of the time standing up and going, actually, we need to think about the fact that our healthcare system is based on compensating people for procedures. It's really driven to make people do more. We don't compensate our GPs enough when, if we did and we actually invested in that system, that will have magnitudes of difference for the health of our populations and, building more resilient communities to the impacts of climate change. So I think that is one of the really big challenges. How do we have that conversation that we really need to think about how we redesign Medicare, how we redesign reimbursing our GPs as well, and move away from this system that just makes us do procedures to people who don't always need it. Not good for the planet, not good for people, not good for cost.
What are your trusted sources of information on these issues? So if we come in a bit naive to some of the opportunities and some of the challenges, where can we direct people to go to in this environment of scary information that isn't always trustworthy? Where would you suggest we head to educate ourselves?
That's a big challenge, isn't it? Because there's so much misinformation now and you can find a competing viewpoint on anything. There's a lot of really good places to go now. Now, not everybody wants to delve through the literature and read all the journal articles. That certainly, if that's something that you're keen on, it's a great place to go. Lancet Planetary Health always has a lot of good information on this. There's many other trusted sources. But almost all states now, health ministries have this information available. There's a lot of good non-government organisations like the Climate and Health Alliance, Doctors for the Environment Australia, that have really good kind of entry-level information on their website that sets this out. What are the impacts? What can you do?
Yeah.
What do we need to do? And here is the evidence as to why. So I think if you're looking at those trusted sources, you can find what you need.
And if you want to get involved in the advocacy in this space, are there online groups? Are there, what's an entry point for an emerging climate change advocate in health? Where should they go? Who should they talk to?
Because it can be very lonely. You can feel very siloed and you have this, for many people, it's an existential angst going, oh my gosh, what can I do?
Yeah.
For me, I got involved with Doctors for the Environment Australia. And as somebody who's in medicine, that was a great place to start because I met other like-minded people, kind of found my space and was mobilised in that way. Many hospitals now, many healthcare systems have these groups. If you Google it, go to look, email somebody, there's a lot of people around who are doing this work now. And the Climate and Health Alliance I mentioned before is another good place that's not just doctors, it's climate and health across Australia. So I think with a little bit of searching, there is information about the in for almost everybody, and it's certainly less lonely when you find a group.
100%. Kimberly, the change that we're going to need to make is so fundamental and at so many levels. Sometimes it feels almost impossible to even conceive of. If we're going to take a bite, if we're going to just do a step, what's the first step you want all the healthcare workers listening today to take that first step and do?
To understand that climate change is a serious health problem, that it's not a kind of fuzzy little greenie in the corner thing. It's as crucial as tobacco smoke is to our practice. So that, I think, is the number one thing, is education and understanding. Now, what you do with that, it's different for everybody. For some people, what they do in their day-to-day job, the conversation with the patient, that's what they need to do, and that's their place. And the place for everybody is different. You don't need to be, working for the World Health Organization or the climate champion for your system or have a paid role in this to make a difference. It's seeing where your passion is and seeing where your talents lie and then leveraging your own potential to make your difference is what really matters.
Kimberly, you've made an overwhelming problem sound like something we can all grapple with. I think it's exciting for everyone in health to give this some serious time and commitment and think about the part, as you say, everyone's got a different part to play, but the part they can all play for the improvement of the health of our communities and the wellbeing of our patients. Thank you for your time today.
Thank you so much, Louise. It's been a pleasure.